Okay, so the question that this video is trying to answer is how to take a history from a patient with abdominal pain. Okay, first of all, you have to start with the patient profile, his name, his age, his marital state, whether he's married or not or single. Okay, uh, where does he live? Okay, and what is he what does he do for life? Okay, so this is, you start with the profile of the patient, then you get into the chief complaint of the patient and the duration, if he whether he is an ER patient or outpatient clinic. Okay, and the chief complaint, which will be in this case abdominal pain. Okay, with the chief complaint, you have to focus on the duration of the abdominal pain, whether it is from day to day, hours, and so on. Okay, because some types of pain, like aortic aneurysm, abdominal aortic aneurysm, or the perforated peptic ulcer, for example, will are severe pains that will obligate the patient to come as early as possible. Okay, and some types of pain, the patient may be patient on them for some days. So from the severity and the duration, you can from the duration of the pain, you can have an idea of the severity of that pain. Okay, so after that you go to analyze the chief complaint, the abdominal pain. Where is the site of the pain? If you have a epigastric pain, maybe perforated peptic ulcer, maybe gastritis, maybe pancreatitis, acute pancreatitis or chronic pancreatitis, maybe cholecystitis or gallbladder stone, and so on. Okay, so the site is very important. The onset of the pain, whether it is sudden in onset, gradual in onset, and so on, because peptic ulcer perforation will lead to sudden pain. Other types of pain may be gradual. Okay, the character of the pain, is it tearing pain, is it stabbing, is it heaviness, and so on. Okay, so Socrates, the site, the onset, the character, the radiation. For example, the gallbladder pain will mostly radiate into the right scapula or interscapular space. The pancreatitis will radiate to the back. Okay, the urinary origin pain will radiate to the flanks, and so on. Okay, so the size, the onset, the character, the radiation are very important. The timing of the pain, is the pain constant, or does it happen for some time and then relieve and then come back? When is it relieved? Is it totally away, or the patient is still having some kind of pain? Okay, so the size, the onset, the character, the radiation, and the timing of the pain, the association symptoms. Now, this is the most sophisticated part. Okay, you have to think in each differential diagnosis to ask about the associated symptoms. For example, we have an epigastric pain that is sudden in onset, so we think about perforated or non-perforated peptic ulcer. The association symptoms may be heart pain. For example, the patient may be complaining of heart pain for some time. Okay, and change in stool color if he has bleeding from this peptic ulcer, maybe also hematemesis. Okay, coffee ground, vomitus, and dark stool, melena. Okay, so the peptic ulcer bleeding in the stomach will be affected by the gastric juice, and that will lead to melena and coffee ground vomitus. Okay, so this is the association for peptic ulcer. If we are thinking about pancreatitis, the patient may have some kind of fever, okay, nausea, vomiting, diarrhea. If it is a chronic pancreatitis, patient may have stationuria, diarrhea, okay, and so on. So for the cholecystitis, patient may have again fever, abdominal pain, jaundice, itching, change in stool or urine color, okay, and so on. For now in the bowel, for the inflammatory bowel disease, you have to ask the patient if he has fever sometimes, okay, episodes of diarrhea or constipation, mouth or other oral ulcers, okay, blood problems in vision, if he has some kind of skin rash, okay, joint pain. So this is for the inflammatory bowel disease, ulcerative colitis and Crohn's disease, okay, family history of these things and so on, okay. So so we thought about the the peptic ulcer disease, the pancreatitis, the cholecystitis, okay, and the inflammatory bowel disease. Gastroenteritis and gastritis are also important. So you ask the patient if he has vomiting, okay, again. And now you thought about the tumor, the trauma, you thought about, the inflammation, the infection. Now, tumor, patient may have, for example, gastric tumor or a colonic tumor. So you have to ask a patient about the constitutional symptoms, if he has nausea, vomiting, anorexia, weight loss, loss of appetite, okay, anemia, signs of anemia. So this is for the tumor. And after that, you have to ask about the trauma, if the patient had some trauma on his abdomen, okay. So I'm sorry, trauma is not from the association symptoms, but you may also ask about it. Now, after we focused on the GI system, you have to pass over the other systems, looking for any cause may lead to this type of pain. For example, in order, I have some order in my mind for the systems. So I will pass first on the respiratory system. If we have lower lobe pneumonia, we will have epigastric pain. So I will ask about if the patient is coughing, shortness of breath, secretion from his nose, sneezing. If he has some kind of lower lobe pneumonia, he may have epigastric pain, okay. And now the cardiovascular system, you have to ask the patient about palpitation, chest pain, leg swellings, orthopnea, and so on, because lower lobe inferior MI may be presented with abdominal epigastric pain, okay. So you have to ask about that, okay. So this is for the cardiovascular system. For the hematological system, actually the anemia may be presented with abdominal pain, so you ask again about signs of anemia, shortness of breath, fatigueness, and coldness of limbs, and so on, okay. And after that, you move to the endocrine system. The diabetes may be presented with abdominal pain when we have a case of DKA, for example. So you ask the patient if he has diabetes, polyuria, polydipsia, polyphagia, weight loss, vomiting with this abdominal pain may indicate an attack of DKA, okay. Now the familial Mediterranean fever also is a cause of abdominal pain. So you ask the patient about his urinary symptoms, dysuria, pain, burning sensation, hesitation, so on, okay. because the FMF is a cause of renal failure if it is chronic due to amyloidosis. Okay, then you go over the musculoskeletal system. You ask the patient about some trauma on his abdomen again, okay, or chest. After that, you move to the urogenital system. You ask the patient about urinary symptoms because pyelonephritis may be presented with abdominal pain. So you ask about the urine dysuria, hesitancy, change in urine color, and so on. Okay, there are still some other differential diagnoses that are actually unlikely to happen, just like the for example hydatid cyst of the liver. Okay, for example, also the hepatitis. You ask a patient about travel history, sexual history, and the blood transfusion. Okay, so hepatitis may be a differential diagnosis of that. Okay, so we ask about the site, the onset, the character, radiation associated symptom. Now the exacerbation and the relieving factors. If does the pain increase with eating, because eating, if eating exacerbates the pain, it may be gallbladder origin pain. Okay, especially if it is fatty foods. Okay, also the gastric ulcer will increase with pain. The pain will increase with eating. The duodenal ulcer, the pain will relieve with eating. Okay, uh, so the eating. The second thing you ask about the motion, if the pain is related to leaning downward or lying on bed, because pancreatitis will relieve by leaning forward. So you ask the patient, does the pain decrease with that or increase, or so on? Okay, so the movement, the and so on. So you ask about the relieving and the exacerbating factors. Okay, now the severity of the pain. You ask the patient, putting a scale of 10. The 0 is the least pain that he has ever had, and 10 is the most pain. Okay, and you ask your patient to specify the severity of pain here. Okay, so peptic ulcer perforation is as a severe pain. Okay, you will have guarding rigidity of the abdomen. Okay, and aortic aneurysm rupturing also is a severe pain. Okay, so site onset, character, radiation, exacerbation, relieving factor, and the severity of the pain, the timing of the pain. So this is the Socrates analysis of the pain. Now you pass smoothly over systems again. Okay, you passed over systems. After that, you have to ask about the medical and the surgical history of the patient. Is a patient of DM, hyperlipidemia, alcohol. I'm sorry, DM, hyperlipidemia, hypertension, and so on. The surgical history, if he had other surgeries, for example, if he underwent cholecystectomy, then you can exclude some part of gallbladder diseases. Okay, so the medical and the surgical history. Then the drug history, you have to ask about the non-steroidal anti-inflammatory drugs because they are a cause of peptic ulcer disease. Okay, and other drugs that may be irritant. Okay, some drugs may cause pancreatitis and so on. Okay, so the surgical, medical history, the drug history, then the allergy. Does he have any known allergy? After that, the family history. Is there any family history of pancreatitis, for peptic ulcers, for acute cholecystitis or gallbladder stones, and so on. And then you move on the social history of the patient, asking about the smoking, because as you know, smoking effect on the peptic ulcer is prevention of healing of or delaying the healing of this peptic ulcer. So you ask about smoking. Alcohol also is a risk factor for pancreatitis. Okay, and for pancreatitis specifically, you have to ask about the things that are in gate smash. You know, the G for the gallbladder stone, the E for ethanol alcohol ingestion, the T for the trauma, the S for scorpion bite. For example, you ask the patient if he had scorpion bite and so on. Okay, the mump infection and all these things. So this is how to take a history of an abdominal pain, specifically epigastric pain. I hope it was helpful. Thank you very much for watching this video.